Kia ora, morena. Good morning, everyone. I'd just like to say thank you very much to those three previous speakers, and Dr. Marley's unfortunately had to whip off back to the airport, but I just think they just speak to the heart of what we do in healthcare, and that the connections we make with people is the first and foremost thing, and then it's after that we hope to help that person to achieve health gains. So I think these previous speakers, whilst it's been short, I think you could have a whole week talking about cultural competence and learning how to be better healthcare providers. So I think it's just been so important, and it feels really wrong to go from all that beautiful patient-centric or client-centric stuff to then go, well, I'm going to talk about liver disease. So it just seems a bit of a clang for me, swapping onto this talk. So sorry for the abrupt change in style, what we're speaking at here. So this session was just sort of thrown in as a bit of variety, completely separate from viral hepatitis, hepatitis B, hepatitis C. This is talking about non-alcoholic fatty liver disease or fatty liver disease. This is a condition that is incredibly common in the Western world. So we're just going to talk about that for a few minutes. So broadly in this session, I hope to give you some understanding of the metabolic syndrome and then fatty liver disease. For the people who work, well, for the majority of you who work in primary care, the metabolic syndrome should be absolutely no surprise to you. This is probably your bread and butter, whether you call it or think of it as a metabolic syndrome or not. It's essentially a cluster of any three of the following: high blood pressure, obesity, abnormal cholesterol profiles, and some degree of insulin resistance, impaired glucose tolerance, or type 2 diabetes. And then effectively the next component of that syndrome really is fatty liver disease. There's also other associations with other conditions that come into a person's health because of the metabolic milieu of obesity and insulin resistance, and that includes polycystic ovarian syndrome, gout, obstructive sleep apnea obviously relates to the physical structures of breathing difficulties, which then flow on to cardiovascular problems. A number of cancers have particular associations with the metabolic syndrome, and also, interestingly, cognitive decline. At the cellular level, the metabolic syndrome, you don't when you think about diabetes and hypertension, you're not really thinking inflammation, but at the cellular level, it really is a pro-inflammatory condition. Adipose cells, so when you have central obesity, you have fat cells in your subcutaneous tissues or in your abdomen, and it's those adipose cells previously were thought to be relatively inert, but actually they have a key role in the physiology of the cytokines and the inflammatory process that's going on, which leads to insulin resistance, and then that inflammatory milieu at the cellular level then affects the lining of your blood vessels, and that leads to the increased risk of heart disease and strokes. That's all we're doing for hard science, so we can all relax. This is a very sensitive clicker this morning. So in terms of the outcomes of the metabolic syndrome, very broadly, people with the metabolic syndrome have significantly increased risks of complications relating to diabetes and heart disease, and they die young. So moving to fatty liver disease, or non-alcoholic fatty liver disease, or NAFLD for short, this is specifically the presence of fat or steatosis in the liver cells, in the hepatocyte. So if you do a liver biopsy, you very clearly see that it's just fat globules everywhere. And that's when you've excluded other causes, particularly alcohol, hepatitis C, Wilson's disease, and various other liver conditions. We don't biopsy many people with fatty liver disease, but one of the other names that you may have come across or heard is the phrase NASH, N-A-S-H, and that is short for non-alcoholic steatohepatitis. That is a histological diagnosis. It is purely the finding of fat cells in the liver along with inflammatory cellular processes. So it's effectively a subset of NAFLD. But I don't go looking for it. I don't biopsy people to see whether they have NASH. So it's more of a sort of a research tool. The causes of fatty liver disease are lifestyle primarily, but there certainly is genetic predispositions, and it relates to high calorie diet. You're eating more calories than what your body is using on a given day over decades. Specific dietary components, excess saturated fats, and particularly refined carbohydrates. So that's your highly processed sugars. Any food that you buy and eat from a packet, if you read the ingredients label, you'll probably see sugar, fructose, glucose, maltose, corn syrup. All of those things are different names for refined sugars. And so basically anything that comes out of a packet probably has more sugar in it than you're aware of. I would bring your attention to that sugar film. It's a 2014 movie/documentary, kind of along the same style of Super Size Me, the one that Michael McDonald did probably 10 years ago now. It's probably available somewhere on the internet. That sugar film, it's very interesting, it's very entertaining, so as I say, it's halfway between a movie and a documentary. And it looks at the modern diet, which is high in these refined carbohydrates and sugars, and how you can have the same amount of calories, but if you're having a vegetable and whole food diet and the same amount of calories compared to a standard Western diet, which has got loads of packet food, what's happening at the cellular level in your liver and in your physiology is vastly, vastly different. So even if you're having the same amount of calories, you can do very different things for your health. So I would really recommend tracking down that sugar film and watching it as a training session in your GP practices. For something like that could be an idea. So epidemiology, fatty liver disease is the most common liver condition in the Western world. In terms of people being worked up for deranged liver blood tests, it would be by far and away the most common cause. The prevalence is absolutely frightening. It's anywhere between 1 in 5 and 1 in 3 adults in the Western world. I do not want all these people referred to me in secondary care. So this is where we need to sort of be thinking about it, but not thinking about it too much. The prevalence of NAFLD mirrors that of the metabolic syndrome, and the risk factors for having NAFLD and having poorer outcomes from NAFLD are listed there. So the clinical presentation, really, the vast majority of these people have absolutely no symptoms, and this is essentially, it's a diagnosis made incidentally. Either they have an abdominal ultrasound that's been done because they had right upper quadrant pain and there's found to be steatosis on the ultrasound, or they've been worked up for deranged liver blood tests, or in some cases it can be because of an elevated ferritin and someone goes looking, and that can be the cause. So how do you assess someone with fatty liver disease? As with all medical conditions, take a history, some examination and investigations. So from the history perspective, there's not a lot apart from really just the lifestyle stuff. So what is their weight now? When did they gain weight? So if someone's been looked at because they've had deranged liver blood tests, and then liver blood tests were fine in 2015, in the last 2 years they've gone up. Well, what was your weight in 2015? What is it now? Oh yeah, I've gained 20 kilograms in the last 3 years. There's your answer. Other risk factors for liver disease, so presence of diabetes, alcohol consumption, risk factors for viral hepatitis, and then the family history of liver disease, diabetes, ischemic heart disease and stroke, because these things do have a genetic clustering, and so are they going to be at increased risk of complications because you know that their father had a stroke at 50, their mother had a heart attack at 50, then this person really needs to look at their physiology because they've obviously got genes that's going to lend them to more complications. And the diet and exercise patterns, it's important to know, or what do they do in their day, what are they eating, what exercise are they or aren't they doing, find out what's happening in their life, and then you can help make suggestions about how they can make changes. The examination is just very general. It's just your body metrics. Weight circumference is not something that I generally do in clinic, but it's probably something that you guys in primary care in your diabetes assessments are probably doing, and it would be very relevant when you're doing your lifestyle advice and monitoring over time, even if someone's, I mean, we want people to be losing weight, but even if they don't lose weight, if they can increase exercise in their life and their weight circumference changes, then that probably is a meaningful physiological improvement. If you put that into your baseline assessment and they do 6 months of exercise and they're really disheartened because they haven't lost weight, even if they've dropped a few centimetres on their waist circumference, that is a positive, meaningful change. In terms of the peripheral stigmata of chronic liver disease, as I touched on yesterday, that is really only going to identify people with established cirrhosis. So it's a good thing to keep in mind, but it doesn't, the absence of cirrhotic features doesn't reassure me that there's nothing wrong. So it's only a minor component. In terms of the investigations, it's the general stuff that you're going to be doing in primary care. The comment I didn't make yesterday, certainly in Bay of Plenty, I don't know about other regions around the country, if you took LFTs on your panel, you will not get an AST. An AST is incredibly useful in hepatology to work up your hepatitis C. You need an AST to do your APRI scores, and also to work up fatty liver disease, you need an AST to do some of the calculations I talk about later. So if in your region you do not get AST on your standard LFT panels, if you're doing a lifestyle assessment with someone with diabetes or heart disease, please tick an AST as well. In terms of fatty liver disease, interestingly, the most common pattern of LFTs for people with fatty liver disease is actually for their LFTs to be normal. So this is why it's not something that can really be screened for. However, if the LFTs are abnormal, actually it's more common to have a slightly elevated GGT and ALT, maybe just in that 1 to 2 times the upper limit of normal. So it's often just a non-specific low-grade mixed picture, and that would be what we'd see for fatty liver disease. If someone's being looked at from the perspective of you have abnormal liver blood tests, what's going on, so if that's sort of what the point of entry into the thinking about their liver is, then you need to consider all the other causes of liver disease. So this is your sort of standard panel, if you like, for deranged LFTs. What happens to people with NAFLD? So if a person has fatty liver disease, it's actually unlikely that their liver is going to cause them problems in the future. The presence of fatty liver disease is a marker of the metabolic syndrome, and they are more likely to die of heart disease and stroke and die young from heart disease and stroke than they are to run into problems with their liver specifically. So the ones that see me in secondary care, I've done all this workup of their liver, and then I turn around and say to them, your liver's not going to cause, unlikely to cause you problems in the future. Heart disease, diabetes, heart disease, diabetes. It's all about that, which is why it's so important for primary care to be thinking about it. Only a proportion of people with fatty liver disease will go on to have progressive and problematic liver disease, end-stage liver disease and cancer. The predictors of that really are the presence of fibrosis in the liver. If there's fibrosis present in the liver, then that's the ones that are going to potentially go on and get more complications specifically of their liver disease. And all the other predictors of worse outcomes are listed there, and that mean that those people are more likely to have the heart disease and the strokes. I'm not worried about you guys to get a grasp of the numbers here. Suffice to say that people used to think of it as steatosis, so fat cells in the liver, and then a progression through an inflammatory process, and then a progression to cirrhosis and scarring. We now know that it's not that straightforward. People who can go from fat cells to scarring without having gone much through the inflammatory process, and people can go back and forth between those stages of having inflammation present and having some fibrosis present, and then it can get better. The interesting thing to note, though, is that the complication of hepatocellular carcinoma, for the majority of liver conditions, it would be fair to say that you're only going to get liver cancer if you have cirrhosis. So you could have all sorts of middling damage in your liver, but you're only at risk of liver cancer if you have cirrhosis. There was always, and is always, one exception was hepatitis B. You can get liver cancer in non-cirrhotic hepatitis B. Then the addition that's coming through in the liver specialty now is that Fatty liver disease is also a significant exception to that. So we know that about a third to a half of people with fatty liver disease who get cancer do not have cirrhosis, which is just mind-blowing for us as liver specialists, because we've always said that, okay, once you have liver cirrhosis, we'll be doing surveillance and screening for you to monitor whether you are going to pop up a liver cancer. But we now know that half of the people with fatty liver disease who get cancer don't have cirrhosis. We cannot surveil, thousands and thousands of people in the community who are walking around with mid-level degree of fibrosis in their liver. So that's just a bit mind-blowing. In terms of screening, no. I do not want you screening for fatty liver disease in primary care. The conditions that lend themselves to screening programs, and I'll draw you, pap smears for cervical cancer, mammograms for breast cancer, bowel cancer screening, which we're coming to shortly. For a screening program to work, it has to have a disease that causes harm, a disease that you have treatment for that you can reverse the likelihood of that harm, a test that is easy, cost-effective, safe, sensitive and specific, and it's got to be cost-effective in the population you're choosing. None of that exists for fatty liver disease. It is not appropriate to screen the whole population because we don't have a cure, we don't have an easy test for it, so broadly speaking, don't go looking for it. However, it is reasonable to think about, well, who are the people who are at highest risk of running into liver-specific complications? And that is your people who are age over 50, who have diabetes, and particularly those that are male and have one or two other features of the metabolic syndrome. They are the ones at highest risks of having problematic liver disease from their fatty liver disease. And that the guidelines would suggest that your first screening tip should be to do an ultrasound. Boom, doesn't work in New Zealand because GPs can't request an ultrasound for screening of fatty liver disease. That would just get rejected by most DHB radiology departments straight off the bat. So again, it's very difficult and impossible to screen for fatty liver disease. The biomarker scores, the fatty liver index, if you're suspicious that someone has fatty liver disease, you can do that. And as I said, LFTs themselves are a poor indicator. Sorry. Had that slide not been up? So that's the slide I was just talking to, apologies. So yes, in people with high risk of progressive liver disease might be appropriate to screen. So in terms of, you've got a person with fatty liver disease or highly suspicious for fatty liver disease and you want to assess them, the key things really are, we're wanting to assess, do they have fibrosis? Is this person at risk of liver-specific complications? Or is it a matter of, no, you've got fatty liver, let's just work on your cardiovascular and diabetes? And so the assessment of liver fibrosis is really the important thing. And there's a number of things you can do. In primary care, we can do blood test scores, and then there's imaging, and then obviously liver biopsy. So I think this is some things I'd like you to take away. The two main blood test scoring systems that are very appropriate to be done in primary care. So the first one there is the NAFLD fibrosis score. Both of these are on the MD Calc app. I don't know whether you have these on your smartphones or on your desktops. So the NAFLD fibrosis score requires knowledge of a person's age, BMI. It's a yes or no for presence of impaired glucose tolerance or type 2 diabetes, the ALT, AST, albumin and platelets. And also the FIB4 is just slightly less parameters. So if I'm getting a referral to secondary care, my person's got, my 40-year-old's got some fatty liver on ultrasound, please see them. I will decline that referral and say to the GP, please do a NAFLD fibrosis score, please assess their diabetes and cardiovascular disease, and only if they're at risk of progressive or advanced liver disease, refer it back to me. So I want this being done in primary care first. Both of these scores will generally spit out a numerical number. I'm not worried what the number is. It's the calculator will also then say high risk of advanced fibrosis or cirrhosis, low risk of advanced fibrosis or cirrhosis, or indeterminate. And both of these scores have a definite indeterminate grade, which is the nature of the beast. So essentially the suggested algorithm for assessment of fatty liver disease is and everything in blue is in primary care, and everything in green is secondary care, is to do the non-invasive scores in the community. And if the scores predict a low chance of advanced fibrosis, then it's to stay in primary care, and then your management is focused on cardiovascular disease. And I'll come to that a little bit more. If the non-invasive scores suggest an indeterminate or a high risk of advanced fibrosis or cirrhosis, then that's appropriate for them to be referred to secondary care. I'm going to see them in clinic, take a history, look for, confirm that it is fatty liver, exclude other causes of liver disease, and then do some kind of further assessment to try and weed out who's got advanced fibrosis and who doesn't. Different studies in different parts of the world have suggested that when you go through this process, invariably you're going to have 60% go down there, about 30% may need further assessment, and then once we've looked at them in secondary care, there ends up really only being about 5% that stay down here, and the majority will come back into primary care. So what am I doing with them in secondary care? I'm going to request an ultrasound because I get them and you guys don't. And specifically what I'm asking for from my sonography and radiology colleagues is any evidence of steatosis, any features of cirrhosis or portal hypertension. So when you're reading the ultrasound reports, if you've got people in primary care who have had an ultrasound for whatever reason, the words that I'm looking for is increased echogenicity. That means that the liver is appearing whiter on the ultrasound probe, and that whitening of the liver compared to what it should look like, that means it's fatty. And then it's, well, what's it fatty from? So increased echogenicity means that there's increased steatosis present, and then I'm looking for any evidence of damage. And then the ultrasound by itself is not giving a measurement of stiffness. That's where we need a fibroscan, or some of the modern ultrasound machines are able to give an elastography score. So I will often write on my reports, and my radiologists now know that not only do I want the description of what the liver's looking like, I also will say elastography score, please. If I was in a DHB that had easy access to a fibroscan, I'd just be getting my liver nurses to be doing a fibroscan, but I personally don't have a fibroscan machine in my department, so I'm relying on radiology for an elastography score. MRIs is really only research only. I think I've got a comment on fibroscan further up. So coming to a case, this is a 61-year-old male. He was seen in 2016, horrendous HbA1c, high blood pressure, and hyperferrous anemia. And he had deranged LFTs, which I'll show you a bit more in a moment. He had steatosis on an ultrasound, and he did have access to a fibroscan, and he was F2 fibrosis, which is sort of in the middle. So those are his bloods. I don't know this guy's alcohol history. I believe that there was some alcohol in the picture, so this is not probably the perfect case example, but I think it still paints a good picture. So GGT 500, ALT 300, AST 200. That's wrong, it's 1200, but anyway. When we are looking at alcoholic liver disease, you can get a very mixed picture on the LFTs. Classically, we'll see a GGT will be up. But as I say, GGT can be up because of metabolic, because of fatty liver. So if you're talking to someone and their GGT is 200 and you say, do you drink? And they say no, and you think, oh, you're lying, your GGT's up because GGT goes up in alcohol. GGT goes up because of metabolic. So you could have an abstinent person and they've got a GGT that's up. So don't always assume that GGT means alcohol. And classically, if the alcohol is the main driving picture behind the process, your AST will be higher than your ALT for alcoholic liver disease. But again, that's in the classic scenario. And obviously, yeah, all of this is pretty bad as well. So he managed to take on board advice and went away, and things improved. There we go. Sorry. So just completely normalised. The ferritin went from 1200 to 300. His diabetes disappeared. And that's just with lifestyle change. So I know that this is a marked example, but it works. It really, really does. So you can see that, you know, that person in your secondary care clinic, you can talk to them until you're blue in the face about metformin and glycoside. You're not going to move the needle. If they can get rid of this, then they've reversed the physiological processes that's happening in their liver, reversed the insulin resistance. They don't need medications because they've just cured themselves of their diabetes. So it's just lightning bolt stuff. What we know is that we would say to people, you know, if someone weighs 110 kilograms, even if you can we say aiming to lose 5 to 7% of their body weight will make a meaningful difference to the physiology of what's going on in the liver. So we're not asking for a 110 kilogram person to get back to 70 or 80 kilograms. I would say to them, can you get down to 105? Can you get down to 100 kilograms? That will make an improvement. Small improvements in weight make a difference at the physiological level. And likewise, if you can change someone's diet and they can do more exercise, so even if someone's doing more exercise, again, it changes the physiological milieu in the liver. Even if their weight doesn't change, if their waist circumference might come down and their numerical values might improve on some of their bloods. So it's not about getting back down to 70 kilograms, it's about changing the diet, putting more exercise in, and it will improve the overall physiology. In terms of diet, I think, as I alluded to with that sugar film, the key issues really is the refined carbohydrates. So anything in a packet's got more sugar in it than you could possibly be aware of. Lipton's iced tea, I use that as an example. It's got 5 teaspoons of sugar per 100 mils. Iced tea. You know, so really drink water. Exercise, we talked about that. Pharmacotherapy, you know, the drug companies are enthusiastic in this area. If someone can come up with a cure for fatty liver disease, they're going to be printing money because obviously the prevalence of the condition around the world. There's lots of drugs that are in phase 2, phase 3 clinical trials, and some of them are showing improvements in the surrogate markers of liver disease. That, you know, if you do an AST and ALT and a FibroScan 6 months later, yes, there's improvements, but it takes long-term studies to prove differences in the mortality outcomes. So there's work being done in this area, but at the moment there's no specific prescription that I can do apart from lifestyle. So the key factors for management in primary care really is also the assessment and management of cardiovascular disease, because this is what people die of. And I'm not going to tell primary care staff how to do a cardiovascular examination or treatment, because you could probably teach me about that. So take-home points, fatty liver disease is incredibly common. It's a component of the metabolic syndrome. The key things that I'd like primary care to do is to weed out those that are at high risk of advanced fibrosis or cirrhosis and refer them along to your secondary care clinics. And the rest of it is, you know, becomes a part of what you're doing anyway with your diabetes and heart disease. Cool. Any questions?